الرحيم. أنا أبو بكر نشار، أنا جينيكولوجيست، وأنا سعيد إن أنا أكون موجود مع حضراتكم. You can find this lecture and more than 400 lectures on my scientific page on the Facebook and also on the website SlideShare, free download. I will discuss today the polycystic syndrome and type 2 diabetes. I will address 7 items. What is the prevalence of diabetes in Egypt? How the polycystic syndrome is a lifelong syndrome, and if there is a link between polycystic syndrome and type 2 diabetes or not. Are we going to screen for diabetes in the polycystic syndrome? Are we going to screen for the insulin resistance? How to prevent diabetes in polycystic syndrome? Let us start the first about the prevalence of diabetes in Egypt. And according to the International Diabetes Federation, Egypt is the 9th leading country in the world for the number of patients with type 2 diabetes. But the most important, there is tripled. This prevalence is tripled over the last 2 decades. What is the explanation of this? We can explain this by the obesity, the physical inactivity, and the change in the eating pattern. But this is all over the world. What is peculiar or unique for Egypt? For Egypt, the increased incidence of type 2 diabetes is related to the increased exposure to environmental risk factors like the pesticides and the increased prevalence of chronic hepatitis C. The second point we discussed, polycystic syndrome is a lifelong syndrome. And the last theory, it develops in utero. It develops in utero through developmental programming. And if we look here, this is the manifestation of the polycystic syndrome in utero in the form of small baby syndrome or intrauterine growth restriction, in children in the form of exaggerated adrenarche, and in adolescent and adult in the form of the polycystic syndrome, while in the post-menopause, the metabolic syndrome, the cardiovascular disease, the endometrial hyperplasia, and cancer. Again, in adolescent, the manifestation of polycystic syndrome are menstrual, hyperandrogenic, and reproductive, while in the old, it is metabolic. And this is why, if you see here, the patient will go before the age of 40 to the endocrinologist, to the diabetologist, and to gynecologist. But above the age of 40 to cardiologist, diabetologist, and gynecologist. The long-term morbidity of polycystic syndrome, the type 2 diabetes, which increased about 6-fold, the metabolic syndrome, the cardiovascular disease, endometrial hyperplasia, and cancer. Not only this, but when the patient got pregnant, gestational diabetes is increased. Not only this, the offspring of this lady will suffer from metabolic and hormonal profile disorders. So we can summarize in polycystic syndrome, there is increased the risk of gestational diabetes, impaired glucose tolerance, and type 2 diabetes. And this risk is regardless of age. This risk is independent of, yet exacerbated by obesity. But very important thing, there is ethnic or ethnicity will affect the incidence of diabetes in this condition. It was found that it is 5-fold in Asia, while in America 4-fold only, and in Europe 3-fold in Europe. The third point to be discussed, if there is a link between polycystic syndrome and type 2 diabetes, we will discuss this at 3 levels. First, epidemiological level. Second, pathogenic level. Third, genetic link. For the epidemiology, polycystic ovary syndrome increased the prevalence of glucose intolerance, type 2 diabetes, and metabolic syndrome, as you mentioned. And in polycystic ovary syndrome and type 2 diabetes, both are associated with metabolic syndrome. Both are obesity-related condition. What is about the pathogenic link? The insulin resistance is a feature of many women with polycystic ovary syndrome. And it is important, the insulin resistant, in the pathogenesis of both polycystic ovary syndrome and type 2 diabetes. What is about the beta cell dysfunction? It is one of the cardinal features of type 2 diabetes, leading to insulin deficiency. It is confined to type 2 diabetes and represent an important distinction between type 2 diabetes and polycystic ovary syndrome. What is about the hyperinsulinemia? Hyperinsulinemia plays a key role in development of polycystic ovary syndrome. Insulin will stimulate the ovarian Zika cell, enhancing the biosynthesis of androgen, and the androgen will lead to arrest of the ovarian follicle development. That is the pathogenesis of the polycystic ovary syndrome. What is about the genetic level? Variants in two genes have been demonstrated to display a powerful association with type 2 diabetes. But there is no evidence to implicate these two genes in the development of polycystic ovary syndrome. Association of the FPTO variant with type 2 diabetes is well established. So we can conclude that genetic architecture of these two conditions is particularly distinct. We can summarize the link between polycystic ovary syndrome and the type 2 diabetes. The link stems from association of each condition with obesity and insulin resistance. Type 2 diabetes develops in the context of insulin resistance combined with beta cell dysfunction, insulin deficiency, hyperglycemia, while polycystic ovary syndrome develops in the context of insulin resistance and compensatory hyperinsulinemia. Polycystic ovary syndrome increases the risk of insulin resistance and type 2 diabetes. This is well known. And the risk factors for insulin, for the glucose intolerance in women with polycystic ovary syndrome, many: age, high body mass index, high waist-hip ratio, family history of diabetes, and environmental factor. As I mentioned, the last theory for the development of polycystic ovary syndrome, it develops in utero. And the low birth weight and or the size for gestational age have been implicated in the pathogenesis of polycystic ovary syndrome, and it is associated with insulin resistance and glucose intolerance in some, but not in all studies. The mechanism is unknown, but it may be an alteration in birth weight reflecting in utero gross nutritional status. Also, there is a proof for this in the non-human primates. In utero androgen exposure will lead to defect in the insulin secretion and action in the adult life. Are we going to screen for type 2 diabetes in polycystic ovary syndrome? Let us go to the guidelines of the ISHRI in 2018, recommending in all with polycystic ovary syndrome, the glycemic status should be assessed. Should be assessed at a baseline, and then every 1 to 3 years be based on the presence of diabetic risk factors. And these risk factors, if the body mass index is more than 25 kilogram per meter square, if we have a history of abnormal glucose tolerance, if there is a family history of diabetes, if there is hypertension or high risk ethnicity. Oral glucose tolerance test is recommended, otherwise fasting glucose or hemoglobin A1C should be performed. The oral glucose tolerance test should be offered in all with polycystic ovary syndrome when planning to get pregnant or when she is asking for fertility treatment. And during pregnancy, the oral glucose tolerance test should be done before 20 weeks gestation and also again between 24 and 28 weeks gestation. The guidelines of the American College of Obstetricians and Gynecologists in 2018, women with diagnosed polycystic syndrome should be screened for type 2 diabetes and impaired glucose tolerance with a fasting glucose level followed by a 2-hour glucose level after 75 gram glucose load. It is recommended to screen, as we mentioned, for type 2 diabetes in the polycystic syndrome. It is recommended to screen for insulin resistance. The answer, no, it is not recommended. But it is recommended to look for the metabolic syndrome. And this is the criteria of the metabolic syndrome, as we know. And it was found that the metabolic syndrome, its prevalence is particularly high in polycystic syndrome if the patient is young, if she is overweight or obese, if there is hyperandrogenism, and this is very important, if there is oligomenorrhea and amenorrhea. And that's why we have 4 subtypes of polycystic syndrome. We have the hyperandrogenic and the non-hyperandrogenic. And in the hyperandrogenic polycystic syndrome, the incidence or the risk of the metabolic syndrome is high, and this is we should look for the metabolic syndrome if we have hyperandrogenic polycystic syndrome. Again, the guidelines of the WHO not recommending to screen for the insulin resistance in the polycystic syndrome. The last point to be addressed, how to prevent the type 2 diabetes in polycystic syndrome. Lifestyle intervention and metformin significantly reduce the risk of developing diabetes in women with glucose intolerance. Lifestyle modification reduce the progression from glucose intolerance to diabetes mellitus in general population and also in polycystic syndrome. It is the best approach and should be the first line for all the overweight and obese polycystic syndrome. Exercise combined with diet reduces diabetes risk comparable or even better than medication. What is about the metformin? Metformin, the effects of metformin, it will lead to a reduction in the incidence of type 2 diabetes in high-risk population. This is the study of the diabetes prevention program, including more than 3,000 patients, and it was found that the effect of metformin is less than the effect of the lifestyle modification. Metformin will decrease the incidence of type 2 diabetes by about 30%, while the lifestyle modification by 58%. That's to say, double the effect of the metformin. Metformin will lead to improvement of the glucose tolerance or keeping it steady. Metformin, there is inconsistent decrease in weight. So the recommendation of the American College of Obstetricians and Gynecologists in 2018 currently is there is insufficient to recommend metformin to prevent diabetes in polycystic syndrome. However, we can use the metformin in 2 conditions. If there is an impairment of the glucose tolerance or there is metabolic syndrome. To come to the conclusion, the link between polycystic syndrome and type 2 diabetes stems from obesity and insulin resistance. Polycystic syndrome increases the risk of insulin resistance and type 2 diabetes. Regular screening is recommended for early identification of impaired glucose metabolism, particularly overweight or obese, and if there is a family history of type 2 diabetes. Prevention of type 2 diabetes in patients with glucose intolerance is primarily based on the lifestyle changes as we mentioned. Metformin might be considered in selected cases. Shukran.